Good afternoon. I would like to thank the organizers for inviting me, and especially Dr. Sajiv. I have the honor of closing this meeting, and 2 years ago I had the same honor closing the European Renal Association meeting in Vienna. So let's see how it will go today. I work at the University Hospital in Copenhagen, National Hospital, and I'm a chief of vasculitis and therapeutic plasma exchange unit. We are the biggest hospital in the eastern part of Denmark. We have 1,200 beds and 4,500 employees. At my department of nephrology, we have 48 beds, we have 25 doctors and 12 consultants. We performed during 1 year approximately 1,200 therapeutic plasma exchange and 150 immunoadsorptions, included 75 ABO glycorex procedures and 75 with protein A as adsorbent. We perform approximately 30 ABO incompatible kidney transplants, and at the same time I follow a cohort of ANCA-associated vasculitis patients, and we participate in a big plasma exchange, not multi-center but multi-continental study with 700 patients included, enrolled, and the first results will be ready this ISN meeting in the autumn in New Orleans. As it was mentioned, I have been president of ISVA for the last 2 years, and as you can see, ISVA has endorsed your Avatar 2017 meeting, and since 1990 I have been a member of EUVAS, the European Vasculitis Study Group, and EUVAS Scientific Committee. This May we had a beautiful plasma exchange or apheresis congress with approximately 400 participants, and I would like to mention that the most exciting presentation on sepsis during this meeting was from Professor Stefan Mitzner's group, when they introduced a new concept of combining plasma exchange and absorption by introducing the blood group MAGE granulocytes. Very exciting. But let's speak about sepsis and plasma exchange. And I have to admit that having at our staff such experienced anesthesiologists like Professor Anders Perner, who was the man who published the results on Hess starch and showed that it can introduce and provoke the acute renal failure, we don't perform standard plasma exchanges for the sepsis treatment. It comes on the passionate or as a rescue therapy method. So I take you over the border to Sweden, where my very good friend Bernd Stegmaier, who is a monumental person in plasma exchange research, has been using plasma exchange for sepsis. And back in 2003, he published this paper on 76 patients with sepsis. It was a retrospective study, and he showed using centrifuge technique because he shown complement could be activated when the membrane filters were used. He showed very high survival of 82% of the patients plasma exchange during this decade. Those patients were followed. Because there's no doubt about the rationale for plasma exchange. As you know, plasma exchange removed the harmful substances like bacterial endotoxins, activated complement and coagulation factors, inflammatory cytokines and chemokines. If you use fresh frozen plasma as a replacement fluid, substitution fluid, you supply coagulation factor, natural anticoagulants, and when sepsis is present together with TTP and Adams serotonins are decreased, you will also supply the coagulation factors, as I mentioned. And plasma exchange is normally a standard procedure when you can remove everything, but especially in Japan, our colleagues were using secondary filters in order to decrease loss of albumin or fibrinogen from the plasma. So they introduce the filters with lower cut-off EC2A and AC5A. So the first one can remove cytokines and save, retain albumin, and the second one can remove IgG and save, retain fibrinogen. Those are those plasma fractionators. This picture is taken from our colleague presenting these results earlier this afternoon. And those filters can be used as the primary filters, but for the plasma exchange, they can be used as the secondary filters, and in this way, our colleagues in Japan can avoid using too much albumin or fresh frozen plasma for the procedure. A very good paper on nomenclature was published lately in 2017 by Villa and colleagues, because there's a lot of confusion about these different procedures, and I will only speak on these two procedures where plasma filter is involved, and the standard plasma, therapeutic plasma exchange, and plasma exchange in connection with adsorbent. And going back to my friend Bernd Stegmaier, he in 2012 wrote a review on septic shock and plasma exchange, and he proposed changing from conventional apheresis to adsorption therapies. This was based on polymyxin B studies, especially from Japan, and also there's another adsorbent, albumin adsorbent from Fresenius called Matisse, where all the results until now were not positive. So showing the polymyxin column, probably you know that the matrix is polystyrene fibers, and polymyxin B is bind to this matrix. And polymyxin is a circular peptide, antibiotic for gram-negative bacteria. It has strong binding affinity with endotoxin, and it's strongly nephro and neurotoxic if you give it intravenously. So through the last 2 decades, polymyxin B was especially used in Japan, in clinically for more than 1,000 patients. So 2015, Dr. Rimele also mentioned an hour ago, the results of multi-center study in France were very disappointing, especially because patients who were treated with polymyxin B hemoperfusion had higher mortality compared to controls. There have been many comments and some voices that maybe some of those patients had gram-positive bacteria and not gram-negative sepsis, but people were very disappointed. The other study, EUPHRAT study, which Dr. Rimele also was talking about, is interesting because I don't think he mentioned it. It's a double-blind, randomized controlled trial sham procedure with 2 sessions, and they enroll patients with mods higher than 9, and they have especially developed endotoxin binding assay where they go by values higher than 0.6. And the first 248 patients have been published in 2013, where they found the so-called significantly mortality benefit of 5%. Another value they use is a function of endotoxin remove mortality benefit, which was up to 18. This was published in Critical Care in 2015. However, this March, additional 416 patients were enrolled. The results were better, and they were probably look for approval at FDA. I found 2 meta-analysis papers on plasma exchange, and this one, which Dr. Emily was also speaking about, is more positive because they are both hemofiltration and plasma exchange studies involved. Totally 16 studies were included for meta-analysis, and they started with 1,700 different publications on Medline. Those 2 subgroups were positive when we look at hemofiltration with hemoperfusion and standard plasma exchange. And when we look at plasma exchange, the 2 studies of Rivers and Bussund were showing the reduction in mortality with relative risk of 63%. The same also is when you combine hemofiltration with hemoperfusion, and relative risk was down to 69%. So those conclusions were that the positive results based on this meta-analysis are usually in the subgraph of plasma exchange or using polymyxin B hemoperfusion. This is why this French multicenter trial was very surprising after this meta-analysis were published. The next meta-analysis were just working with plasma exchange. No hemofiltration were discussed, and Emily Reimer from US, based on 1955 records, find 4 trials, and they were included in analysis.